to Not So Complicated, and this is a special request video because one of our viewer asked to make a video on topic adrenal steroids and congenital adrenal hyperplasia, so we will focus on that. So if you didn't know that we do a special request video, now you know. And if you have any curiosity or confusion in any topic, you can comment down, right? So let's start without further delay. So we'll start with basics, right? So adrenal gland is composed of like adrenal cortex, that is the outer portion, adrenal cortex, that is the outer portion of the gland, and then adrenal medulla, that is the inner portion of the gland, right? So adrenal cortex is further divided into three different regions, and the first region is zona glomerulosa, where they secrete mineralocorticoids like aldosterone and 11-deoxycorticosterone, right? So in zona fasciculata, they secrete glucocorticoids like cortisol, cortisone, and corticosterone. And in zona radicularis, they secrete sex steroids hormone like androgen, estrogen, and progesterone. In adrenal medulla, they secrete epinephrine and norepinephrine, right? So we'll focus on steroids this time. So we have to know the steroidogenesis, like we have to understand how the hormones are forming to understand the lesions or anomalies like this, right? So let's begin. So every steroid hormone begins its synthesis from cholesterol, right? So this cholesterol, in presence of P450 SCCR star protein or also desmolase, it will get turned into pregnenolone, right? And this pregnenolone, in the presence of 17 alpha hydroxylase, it forms 17 hydroxylase pregnenolone, and in the presence of 3 beta HSD, it will form progesterone. So from pregnenolone, there are two hormones coming, right? 17 hydroxyl pregnenolone and progesterone. And this progesterone here, in the presence of this 17 alpha hydroxylase, again forms 17 hydroxyl progesterone, right? So the goal of these three substrate is to form 17 hydroxyl progesterone at this case, right, in glucocorticoids. So this pregnenolone converting to 17 hydroxyl pregnenolone in the presence of 3 beta HSD, just like 3 beta HSD here, it will get converted into 17 hydroxyl progesterone, and this pathway, from this pathway to, it will get converted into 17 hydroxyl progesterone, right? So in mineralocorticoids, to form aldosterone, what actually happens is this progesterone, in the presence of 21 hydroxylase enzyme, this is very important for our congenital adrenal hyperplasia, because this is the most common enzyme that is deficient, that is lacking in that lesion, right? So in the presence of 21 hydroxylase enzyme, progesterone will turn into deoxycorticosterone, and in 11 beta hydroxylase, it will turn into corticosterone, and in the presence of 18 hydroxylase enzyme, it will turn into 18 hydroxyl corticosterone, and then in presence of 18 oxidase enzyme, it will form aldosterone, right? So this is the synthesis of aldosterone right here, and this 17 hydroxyl progesterone what has formed in the presence of 21 hydroxylase enzyme. Again, you have to remember this, right? So 21 hydroxylase enzyme is the primary enzyme that is forming aldosterone, and that is forming cortisol here. So in presence of this enzyme, 17 hydroxyl progesterone will get converted into 11 deoxycortisol, and in the presence of 11 beta hydroxylase enzyme, it will get converted into cortisol. Now aldosterone and cortisol are formed, right? So let's talk about sex hormones here. In presence of 1720 lyase, 17 hydroxyl pregnenolone will get converted into dehydroepiandrosterone, DHEA, right? Dehydroepiandrosterone. You have to remember this, and then it will get converted into dehydroepiandrosterone sulfate, which is active metabolite form of this, and also 17 hydroxyl progesterone will convert into androstenedione in presence of 1720 lyase, right? So this androstenedione has two fates, just like this has two fates, right? So in 17 beta HSD, in the presence of 17 beta HSD, dehydroepiandrosterone will get converted into androstenediol, and in the presence of 3 beta HSD, it will form testosterone. So our goal is to form testosterone, right? So in the presence of 17 beta HSD2, androstenedione gets converted to testosterone. and androstenedione in the presence of aromatase enzyme. This is the most common, like you have to remember this enzyme. Androstenedione will be converted into estrone, and in the presence of 17 beta HST, it will get converted into estradiol, right? Also, testosterone gets converted into estradiol in the presence of aromatase enzyme. So there are three enzymes that you have to remember here. One is 21 hydroxylase enzyme, another is 17 beta HST enzyme, right? And then another is 11 beta hydroxylase enzyme. Because you can also remember 18 hydroxylase enzyme. You don't have to remember this entire synthesis pathway. You just have to remember this portion here. Progesterone to deoxycorticosterone, and this 17 hydroxyl progesterone to 11 deoxycortisol, right? That is all you have to remember for congenital adrenal hyperplasia disease. So that is synthesis here. We have formed aldosterone, cortisol, testosterone, and estradiol or estriol. It will get converted into estriol too, right? So let's go. So brief functions of adrenal steroids are that in aldosterone, they increase the secretion of an reabsorption of Na+, and along with H2O, wherever there is Na+, there is H2O reabsorption, and also H+ and potassium secretion is the function of aldosterone. And cortisol, it increases Na+ and H2O reabsorption, H+ and K+ secretion, proteolysis also, it will increase gluconeogenesis. So in Cushing's disease, that is increased cortisol secretion, gluconeogenesis is maximum, that causes adrenal diabetes. We'll talk about these diseases like aldosterone diseases in Conn syndrome, primary hyperaldosteronism or secondary hyperaldosteronism, and Cushing's disease, Addison's disease. Here in pheochromocytoma, we'll talk about these diseases and how the tests are done, like dexamethasone suppression test. We'll talk about in separate video. We are focusing in congenital adrenal hyperplasia now. So lipolysis, anti-inflammatory effect, anti-allergic action, immunosuppressive effect, resistance to stress, these all are the functions of cortisol, right? So in androgen and estrogen, development of respective genitalia. That means estrogen will lead to development of female genitalia and androgen to like male genitalia, and also secondary sexual characteristics in both males and female, right? So the functions of epinephrine and norepinephrine is that, or adrenaline or noradrenaline is that they increase heart rate and also force of contraction of heart rate, heart muscles, and increase in cellular respiration, rate of cellular respiration, conversion of glycogen into glucose is increased, and it dilates bronchioles and vessels of skin and viscera, right? So you have to remember this. Vessels of skin and viscera are dilated by adrenaline and noradrenaline, but other vessels are constricted. You have to remember this, right? So that is brief functions. Let's talk about adrenogenital syndrome. Adrenogenital syndrome and congenital adrenal hyperplasia are two different things. So to remove the confusion, we have to study adrenogenital syndrome too. So due to tumor in zona reticularis, that is the third region of the adrenal cortex, zona reticularis, where there is increase in androgen and estrogen synthesis, right? So thus there is an increased tendency of secondary sexual characteristics of opposite sex. That is where it happens. In adrenogenital syndrome, there is increased tendency of secondary sexual characteristics of opposite sex. So in male, there is gynecomastia, that is enlargement of breast here, loss of interest in females, decreased libido is sex drive, and feminization, all the features that resembles of female happens, right? In female, what happens is virilism, that is increase in hair growth, and also deep voice due to testosterone increase, and male type hair growth, amenorrhea, and enlargement of clitoris like penis happens, right? This is adrenogenital syndrome. So to remove the confusion, just in case. So let's talk about congenital adrenal hyperplasia. That is our main topic for today. So it is autosomal recessive disease, and it most commonly occurs due to deficiency of 21 hydroxylase enzyme, but it can also happen due to deficiency of 11 beta hydroxylase, 18 hydroxylase, or 18 oxidase enzyme, right? Not 18 oxidase actually, just 11 beta hydroxylase and 18 hydroxylase enzyme. It can happen like that. So in the synthesis, this is the same chart in a simplified manner. So in the synthesis, cholesterol to pregnenolone, and that to progesterone, that to deoxycorticosterone, right? So this 21 hydroxylase enzyme, like in this 21 hydroxylase enzyme, 21 hydroxylase enzyme. So these enzymes are deficient, right? There are no enzymes like this. So this pathway is obliterated because the primary limiting enzyme is not there, right? So this pathway is obliterated. What actually happens is that this progesterone now gets accumulated. There is a simplified flow chart, we'll talk about it, and accumulated to these regions. These accumulated hormones now get shunted to the formation of androstenedione, testosterone, or androgens. Now they get shunted to this pathway. This actually happens in congenital adrenal hyperplasia. So how does hyperplasia happens? Why hyperplasia? Let's talk about that in a simplified manner. So actually what is happening, 7-hydroxyprogesterone is not getting converted to 11-deoxycortisol in our earlier pathway because there is no 21 hydroxylase enzyme, right? So that is leading to decrease in cortisol enzyme, just like this, decrease in cortisol enzyme and also aldosterone enzyme. And then what is happening is that decrease in cortisol is compensatory increasing ACTH, right? Adrenocorticoid. This ACTH is increased to increase the decreased level of cortisol. There is decreased cortisol, compensatory increasing ACTH is happening, and that will stimulate adrenal cortex, right? That will stimulate adrenal cortex. And the effect of that adrenal cortex stimulation is seen in two ways. What are these two ways? These two ways are increases steroid hormone synthesis and also increase in number of hormone secreting cells, right? So increase in adrenocorticotropic hormone, ACTH, will lead to stimulation of adrenal cortex, and that will lead to two pathway. That is increase in steroid hormone synthesis again. Here it will get accumulated, and then increase in hormone secreting cells. These hormone secreting cells, there is increase in cell number, right? So that is why increase in size of adrenal cortex happens, and thus adrenal hyperplasia happens. That is the reason for hyperplasia, adrenal hyperplasia. So congenital, because there is deficiency of 21 hydroxylase enzyme, adrenal hyperplasia because of this pathway, right? And then this increased steroid hormone synthesis plus 17 hydroxylprogesterone, they accumulate here and they are diverted to androgen synthesis. And androgen synthesis now will appear as clinical manifestations. That is a simplified manner of this disease. Let's talk about the clinical manifestations here. In male, there is precocious growth because there is increase in androgens, increase in penis size at the age of 4 years, and stocky appearance is there. And in female, there is viridism. Female child with male type external genitalia is there. Okay. So in adrenogenital syndrome, there is increased tendency of secondary sexual characteristics in opposite sex, right? Of opposite sex. But in this case, both male and female are experiencing the symptoms of increased testosterone here, because it is not the aromatase enzyme that is affected, it is these enzymes that are affected. So this pathway will lead to increase in testosterone enzyme because there are limited aromatase enzyme. So here you can see there are limited aromatase enzyme in our body. That is why the more testosterone cannot get converted into more estradiol or estriol, right? So testosterone, the estrogen level is normal, but testosterone level are increased. Let's talk about it. So that is why there is precocious growth, that is like increased growth in early age, increase in penis size at the age of 4 years, and also stocky appearance, that is muscular appearance due to the increase in testosterone and the effect of it. And viridism is there, increase in hair growth, or hirsutism, we can say that. And female child with male type external genitalia is there. As I have talked earlier, not only 21 hydroxylase, but also 11 hydroxylase and 18 hydroxylase enzyme can get deficient. So in those cases, like if there is 11 beta hydroxylase enzyme deficiency, the manifestations are hypertension, hypokalemia, virilization, that is ambiguous genitalia, and hirsutism. And in 17 alpha hydroxylase deficiency, there is hypertension, hyperkalemia, delayed puberty, and pseudohermaphroditism, that is both male and female characteristics like 36XY females, right? So that is the clinical manifestation right here. But how do we diagnose this case? There is obviously high 17-hydroxyprogesterone or 21-hydroxylase, and then high 21-hydroxylase deficiency, that is causing high 17-hydroxyprogesterone, and high 11-deoxycorticosterone in the case of 11-beta-hydroxylase deficiency, and there is low cortisol level, high ACTH, and also electrolyte imbalances is there. Genetic testing confirms enzyme mutations, and newborn screening, there is elevated 17-hydroxyprogesterone for 21-hydroxylase deficiency. So that is all about congenital adrenal hyperplasia. Subscribe for more clinical polls, and thank you for staying with me if you are still here. And if you have any request or curiosity or confusion, you can request the topic in the comment section, and I will, as soon as possible, make the video on it. Thank you.